Hello and welcome everyone for tonight's EAO Just Ask. We're all back from our annual congress in Monaco, still have some sun on the face from Monaco, and we're back with our Just Ask format. And this time it's an amazing pleasure because, and it's so important, we have a prosto topic. And we have a top-notch expert this time. We have Professor Amélie Mainjot. Amélie, I tried my very best with my German to do it perfectly. You are the head of the Dental Biomaterials Research University of the prestigious University of Liège. You traveled abroad, you spent time in Paris, you did your PhD about zirconia, and you are an active member of the prestigious EAED community. Amélie, it is just a great pleasure to have you here. Who else could talk about this topic? Zirconia, glass ceramic, hybrid ceramic, or composite? What should we use? You are a clinician and you are a researcher. What else could we have? And with this, I would love to welcome you on behalf of the EAO to this Just Ask format, Amélie.
Thank you very much, Stefan. And first of all, good evening to everyone. It's a huge pleasure to be here and, of course, a big honor to share this Just Ask session with everybody. First, I'm a clinician, and it's very important to say that I will, I think, discuss from really a clinical point of view. So don't be afraid about the word material. And yes, preparing this lecture, I have to say, Stefan, that I have realized that I'm getting old, in fact, quite old. And when you become old, you have more and more of the patient you have treated for a routine checkup. And when you open your waiting room and you look at the waiting room like this, basically, I have realized that now I have two types of patients. And tonight, we will speak about those two types of patients. We will discuss the material choice in these two types of patients. First of all, Mrs. Dream. Mrs. Dream is the perfect patient that I can have. She has never a problem. When I see her in the waiting room, I see that I will save some time, that I will be on time for my schedule. And when I see Mr. Nightmare, I don't know what's your experience, but it's a bit different. I already know that I will be late on my planning because for sure he will tell me, oh, doctor, sorry, but I think I have something broken. This time, could you do something for me? And he has always a problem, and most often it's fractures.
Wow, so Amélie, tonight it seems to be everything is a little different. Normally I present a case and I have the feeling now you bring two cases for me. So we're really looking forward to what we're going to see from you.
Yes, and I will ask you first the question about the material choice, of course, but first of all, I will introduce to you the two patients, and the first one I have been following her for 15 years already, so it makes me quite old. And I think it's really important to say that I'm convinced that the material choice is very important for the implant success, and that we cannot dissociate the two components, the implant and the prosthesis. So let's discuss about the different possibilities for single unit restoration. This is the topic tonight. So, Stefan, Mrs. Dream, my ideal patient. Let's start with the good part.
So she came to me psychologically very good.
Yes. So she came to me to replace the 21. You see that she had an orthodontic treatment, and she had also some old glass ceramic veneers on the incisor. And at the end, after working with my partner, Professor France Lambert, that you know very well, she did some mucogingival surgery. I had to replace those glass veneers, and I performed 3-10 restoration, zirconia-based restoration. It was in 2011, as you can see. It's already a long time ago. some feldspathic veneers, and I had also to replace some two old crowns here on natural teeth, and it was a zirconia framework. So time flies. It's at the beginning of the situation. It's just after treatment, before and after treatment. So everything is all right. And so times fly, as I was saying, and you look 14 years later, it hasn't changed a lot. You see the crowns, you see the veneers, everything goes well. And at 14 years follow-up, you can only notice a small infraposition of the implant, even in this patient, who is not so young, but you always have some infraposition process with implants, and you see that the soft tissue are very nice. It's one of the big advantages of zirconia. It's also the behavior towards the soft tissue. It's really friendly. And she lost an undercrown on the 44. It was 11 years after bonding. And to be honest, I rebonded it and it's still in the mouth. But let's imagine that I decided to remove the tooth and to put an implant. It's a tissue level implant here. And I have now to ask my dental technician to perform a restoration for this tooth. So this is the situation on the lower maxilla to show you that we have some single unit restoration on implants on the 45 or 46. So this is those are single unit restoration, nothing special. You see the maxilla. And now the question is for you, Stefan. What would you do here? What would you say to your dental technician?
Yeah, Amélie, I mean, I really, you get me now, and I'm getting a little nervous, and I would punch that a little bit to our listeners. We have a lot of listeners already logging in from Netherlands, from Sweden, we have Arndt Happe from Germany, yeah, with people from Albania, from Zurich. What do you think? Ask your questions. But now I think it's a little bit on me to give you an idea. We already said in the beginning, I'm a little bit a cross-trained prosthodontist as a periodontist. So if it's Mrs. Dream, that means a little bit for me, anything goes. So she probably has no bruxism, she has no parafunction. I think you placed your implant in a proper position. It's a tissue level implant. So I think you got a high prosthetic connection. So I would probably use a screw retained restoration with the tie base. I'm not sure if you would use again a full zirconia abutment. I will punch that question back to you. So I would probably use a tie base glued to a full zirconia, probably a monolithic restoration in this not so super aesthetic situation. What do you think, Amélie?
I wouldn't do exactly the same jobs, but we will discuss it, and this is why it's interesting. So, of course, when we have to make a choice, the first thing is to look what do we have at our disposal. So we have basically three families of material. If we talk about aesthetic materials, I won't talk about PFM tonight. So we have light-on-based glass ceramics. We know that there are good glass ceramics, the flexural strength, and it's always important to have an idea about the flexural strength of a material. It's around 400 megapascal. And then we have zirconia materials. And zirconia materials, we know that we have now different generation of materials. We have the first one, which is very strong, 1,200 megapascal. And then we have translucent zirconia, which is the second generation. And we have also the last one. You see it, I think?
Yeah.
Because I don't see it, me. We have the high translucency zirconia, which is more recent. And the third family is CAD-CAM composite and hybrid ceramics, which are more novel materials, and that we will also discuss. The flexural strength is much, much lower. You see 150 megapascal. And I forgot to say that we have also new generation of lithium-based glass ceramic because the patent of Ivoclar is finished now. And so we have copies and new materials. So we have basically three families. What evidence, what scientific evidence do we have for this typical kind of choice? In fact, we don't have some evidence, and this is the problem, of course. If we look at meta-analysis and systematic review like this good one for single crowns, we only have first short-term background. It means around 3 years. It's not very long. And in fact, the survival rate are quite high for all the materials, glass, ceramic, alumina, which is not used anymore, so we won't talk about it tonight, zirconia, and they have also reviewed Lava Ultimate, which is a CAD-CAM composite. Lava Ultimate encountered some debonding and fracture, but for the other materials, it goes very well, in fact. And we only have some chipping for the veneer crowns. So when compared to monolithic, in fact, we have, of course, less risk of fracture of the veneering ceramic if there is no veneering ceramic, okay?
Amélie, can I link in here for a quick question? As you already figured, I need to learn. We sometimes see in our perio patients, when we restore them with dental implants, we have a long crown to implant ratio, and we see sometimes debonding of the tie bases. Is that also included in that literature? So the debonding of the tie bases, or not the debonding of a veneered ceramics?
This is a good question. In fact, the Lava Ultimate debonded from the tie base.
Yes. Okay, that's what they mean.
Yeah, yes.
They don't mean a debonding of a veneered ceramic. This what we call chipping.
No, chipping is a fracture.
Yes.
It's the debonding, it's a fracture.
Okay, I got it.
Chipping, it's really a small fracture of the veneering ceramic of the material, whatever the material, it's a small fracture.
Yeah, okay, I got it.
Either repair or polished.
Yeah.
So since we do not have any scientific evidence, we have to rely on our clinical judgment, and I'm convinced that, of course, the choice of the material depends on the clinical situation. In my opinion, there is no universal biomaterial. We really have to discuss the different possibilities in function of the patient, in function of the clinical situation. So if we look at first the oldest material, glass ceramics, what are the pros and cons very rapidly? Optical properties, gloss, it's very shiny, but on the other hand, it wears out less than enamel. And then with time, you have a high occlusion risk. So we have to check the occlusion. It's very abrasive, like feldspathic ceramic too, and veneering ceramic are very abrasive towards the antagonistic teeth. And it's not as biocompatible as zirconia. So towards, if we are talking about a tissue level implant, it's not very important. But if we talk about a bone level implant, and if we need adhesion of the epithelial cells and connective tissue to the prosthesis, it is not at all the ideal biomaterial. We have also to pay attention to the variation in the different materials that are on the market, because since we have now new generation of glass ceramic, we see that some materials are twice less strong than the original. So when you ask for a lithium-based glass ceramic to your dental technician, and I'm happy to see that you don't write on your lab sheet, I just want the all ceramics through retain restoration. So you were able to say, okay, I would like a monolithic zirconia. Here, when you ask for lithium-based glass ceramic, every one of us should know which one does the dental technician use. Because from 400, you can move to 200 megapascal. And the literature shows also that that pressable lithium-based glass ceramic are more performant than CAD-CAM, except for EPS Emax CAD. So the mechanical resistance is lower in general with milled material as compared to press. This is important to know when you ask your dental technician. You should know, okay, which material exactly do you use? So in my clinical practice, I will go for a lithium-based glass ceramic only if I have another restoration in the same material. So for example, in this case, we have to put an implant here. There was a provisional implant, and we have a glass ceramic veneer on the 12th. So with France, we have done an immediate loading procedure here. So extraction, implantation, immediate loading with a zirconia abutment and a PMMA crown. And then I had to go for the final restoration. So I knew I needed a glass ceramic material for the veneer. So I will adapt my choice on the 22 to this glass ceramic veneer. And I will go also for lithium-based crown. And I like to use EPS Emax Press, which is a good material. But I also use Lazy Press from GC, which is also a very good material.
So in that situation, Amélie, you didn't change the abutment. That was already the final abutment you inserted at the time of implantation?
It's a one abutment, one time.
Yeah, perfect. But then that's the perfect indication for it, right?
Yes.
Yeah.
This is the perfect indication. I have this glass ceramic veneer,
Right.
so I adapt the choice to this glass ceramic veneer, and it will dictate the choice of the material for the implant.
Perfect.
And I already have my biological seal here around the zirconia abutment, which was performed the day of the surgery.
What would you do in a case? Let's stick with this case for a second, because one abutment one time is sometimes criticized when you have like a small alteration in the gingival height. What would you do in that case? Would you re-prep the abutment, or would you then just go for a new abutment?
To be honest, I never have this problem because in Liège, we have a completely different philosophy. We have developed the socket management technique for a long time. Okay. And we also always use, it's not me, it's France, because I'm not the surgeon, but she does a lot of connective tissue graft. And in fact, we are used, since they have developed those techniques, my clinical practice has totally changed, because now I always have sufficient soft tissue that I only have to guide in the good position. And so, but I have to say that this type of one abutment one time is not the practice that we still have now. I will show later on that, in fact, we go for provisional. I do prefer to work with screw-it and restoration now.
But so, just in a nutshell, it will happen to people working with one abutment one time. What would be your choice? Would it be allowed to re-prep the margin, or then you have to go for a new abutment?
I would go for a graft.
Okay, I got it. Okay, got it.
Because if my, my specialty is aesthetics. If the neck of the tooth should be there, then I need the soft tissue to be there.
Yeah, you need soft tissue height.
Yeah, I always place the abutment in the ideal position. The margin are always in the ideal position, and this is a prosthesis-driven soft tissue healing.
Okay, got it.
Okay. So, beside glass ceramics, you have zirconia materials, and zirconia materials are, for me, the best materials for implant prosthodontics. Because the best advantage of those materials is biocompatibility, which is at least equivalent to titanium, superior to lithium-based glass ceramic. And for me, this is really important to get this biological seal around the prosthesis when you have bone-level implants. And towards this, this problem, we really need good material from a biocompatibility point of view. And zirconia is really the best material. It's a pure oxide, and pure oxide are totally biocompatible. So in this case, we have to replace the two centrals. So it's guided surgery. We go for immediate loading here. So extraction, implantation, and immediate loading with a PMMA crown on a tie base here. So it's a screw-it-in restoration. It's my first choice today to work with screw-it-in restoration. It's completely manufactured in advance by the dental technician, and the day of the surgery, I just have to screw it. And later on, I will go for zirconia-based restoration with a tie base. It's very important to say that this tie base should be narrow. We pay attention to the emergence profile of the tie base, and the height of the tie base should be at least 2.5 millimeter. And then we have this zirconia material. And you can see in this same image, this is the image is from our team, from one of my clinical case. You see epithelial cells, which were found on all the surface of the zirconia material. It means that you have a very important attachment all around the prosthesis. It's very important to say that the transmucosal part of the prosthesis should not be veneered, because veneering ceramic is not as biocompatible. And then you will have like a ring of soft tissue around the prosthesis with a very strong attachment. All these cells that you see will cover all the zirconia material. And this is really, for me, the best indication of this material is implant prosthodontics, screw-it-in restoration on bone-level implants like here. It's just perfect.
Amélie, can I ask you a question? It is so interesting. Sorry for interrupting you. I am still a gentleman, but it's so interesting. We've been talking about this topic for many, many times. We talked with Thomas Linkevicius. Why is it, in your opinion, important to have a 2.5 millimeter high tie base? I mean, other people say, take a flat tie base and start with zirconia immediately. It's the best material you can use. So why would I use tie base of a certain height?
This is really just a feeling and not the scientific evidence. We have to say it. So the idea is to avoid to have any joint on the first millimeter where you are supposed to have this connective tissue, and the idea is to protect the implant from bacteria and from the penetration of bacteria in this joint. But I don't have any scientific evidence for it.
No, I get your point. I haven't heard that point. I like it very much. You don't like to have these glued gap. I mean, it's a gap.
I do not like glue, not at all. So glue, resin cement is very bad. But
let's put it joint. Yeah, you don't like to have this joint, so you go away with this joint, 2.5 millimeter, and then start with your zirconia. Get it? Good point.
Yeah. But it's theoretical. Because in my mind, for cell adhesion, it's not good. But there are different systems. You know that we have systems that are frictioned and where you don't have any resin cement. There are screws. There are screw systems also, but most of the systems today are glued. In fact,
I get it. Yeah.
And so I don't like to have this joint close to the implant.
Got it.
And since we always put the implant at around 5 from the cervical margins, 5 millimeter, we have the room to place the tie base and then the zirconia material.
Okay, good.
So it's very important to have a good planning. You see in that case, for example, this is very interesting because the aesthetic analysis, she had ortho. You see that these are aligned, but we decided from the beginning to put the neck of the tooth much upper than at the beginning, you see. And so the planning here is very important. The aesthetic analysis and the planning is very important because you have to put your implant quite deep to be able to do this kind of prosthesis. So, but talking about zirconia, when you told me, okay, I will go for a monolithic restoration, Stefan, which zirconia would you use? Do you know the mechanical properties of the crown that you have ordered. Do you know the generation of the zirconia material that you will use?
Now you got me. You got me. I will listen to you now.
So there are different generations of zirconia material. Nowadays, we mainly use the second generation and the third. The third is the high translucent, but to make it highly translucent, they had to increase the content of yttrium oxide. And from now, I would like everybody in the audience to be able to ask to his or her dental technician, what is the type of zirconia that they do use? They have to ask for the yttrium content because it will strongly influence the mechanical properties of the material. The 4Y and the 5Y can only be used for single unit restoration, even if some manufacturers say, okay, you can do a 3-element bridge. I think it's very risky. So the 3Y is the only one you can use for bridges, but it is more opaque. It's more translucent than the first generation, but look at the mechanical properties, they are completely different. So you should know, okay, if you go for monolithic, it's for sure a 4Y or 5Y, even if you can use some second generation in the posterior region. But most often now they use the 4 or the 5. And the problem is here by mistake, the dental technician splinted the two restoration and implants, and you see that during trying, it broke. Because in fact, it was at the beginning of those materials, and I asked him, but what material did you use? Because a first generation should not break. And he told me, okay, it's this material, and I had a look, and it was a 4Y. And 4Y is not strong enough. Anyway, I wouldn't splint those implants, so we separated them. And most of all, we are used to say, okay, zirconia is very white. And you have to say, you have to know that in fact it's due to its high refractive index. It reflects a lot of light. And even if you go for a high translucent material, it remains something which is not so natural. If you look at the aesthetic result, it's not as natural like a glass ceramic. Look, in this case, you have a glass ceramic on the crown just beside the two implant crowns. And I have taken a picture with polarized light, and you see that the result is less natural on the with the zirconia material. Yeah. Moreover, when you have tie base, sometimes if you use a high translucent zirconia material, you can have a grayish effect, like here, of your crown. And typically, I would go for 3Y. In fact, in my clinical practice, I do not use 4 and 5Y. I only use the 3Y, more resistant. Finally, the optical properties of the high translucent are not so beneficial to me. And I'm used to doing with the dental lab a buccal veneering of the framework, whatever, if it's for a crown or for a bridge. In the posterior, it's more a micro veneering. It's around 0.5 of veneering ceramic. In the anterior region, it's more important to get a very good aesthetic result because my patients are very demanding.
Amélie, it's so interesting. I love your work. Can I go back to that grayish thing? I also encountered this. What would you do in that case? I mean, you already elucidated on that, but I think it's very important for all the listeners. Would you change the zirconia material to be more opaque, or would it also be an option to change the connection to a full zirconia abutment?
No, I would preserve the tie base because I think it's very important to have a connection in metal, because only the metal is able to this plastic deformation when you screw it. So it's very important. But here you see that I have compared the 4Y here on the upper side, and on the lower side you have a 3Y. Yeah. My solution here was to move to the 3Y.
Got it.
It was the beginning of my high translucent materials, and now I've changed my mind, and it's always 3Y.
I think that's a very useful point. Thank you.
So on the layer of the veneering ceramic depend on the region. In the interior, of course, I have more veneering ceramic. So the pros and cons of the zirconia material are biocompatibility, strength, gloss. It's not abrasive at all. That we have to know that even if you do monolithic restoration, when I do some posterior restoration, I told you I use the 3Y with veneering ceramic on the buccal side, but the occlusal part is monolithic. And this is not abrasive at all. You have to know, even it's a very hard material, it's not abrasive towards the antagonistic teeth, but it does not wear out. It means that you have a high occlusion risk with time. And finally, the last family is CAD-CAM composite and hybrid ceramic. Those materials are very performant. They have nothing to do with direct composite because they are made industrially. They are polymerized under high temperature. So nothing to do with a classical composite material from your lab or from your office. And you have to know that there are two different families in composite materials. We have dispersed filler, which are like direct composite. It means filler with resin, which are mixed. And beside this, you have hybrid ceramic. So hybrid ceramic is a block of glass ceramic, which is infiltrated with resin, polymerized under high temperature and high pressure. It's very important to make the difference because the properties are not the same. All the materials like Sierra Smart, Grandio, Tritricat, Lava Ultimate, Bryant, Chopu block are dispersed filler. And you have V-Dynamic, which is a patented process for the hybrid ceramic family. But you have only one material, which is really a hybrid ceramic material. We don't have a lot of background with those materials, but we know we have, with my team, we work a lot with hybrid ceramic, so we have a lot of papers about it and research project on dynamic. We have more data with hybrid ceramic, so it's called also PICN, than with the dispersed filler, and we know that we have a wear and an abrasiveness which is similar to enamel. So this is very important in terms of high occlusion risk. It's also a material which has the stiffness, which is comprised between enamel and dentin. So it's a very soft material as compared to zirconia, which is very, very, very stiff. And it bonds well for the bonding to titanium base, easy to adjust and repair. It's less expensive than a pure ceramic. It's easy to machine, but the gloss is lower, most of all on occlusal area, than pure ceramics. And the biocompatibility is inferior to zirconia. It's similar to lithium-based glass ceramics.
Does the gloss wear out in composites like we normally see it? I mean, it will change.
It becomes matte.
Yeah.
But we have done some clinical studies about the wear of V-Dynamic, and we have published in Dental Materials that the wear in quantity is similar to natural enamel.
Okay.
But so it's really biomimetic from this point of view, but the surface on the occlusal area becomes matte.
Yeah.
But when you have some saliva on it, the patient does not notice it. But
no,
you
of course.
Dentist, when you dry it, you see it's matte. Okay.
But you can probably repolish it, right?
Yes, you can repolish it.
Yeah. Okay.
And we have also to say just a word about 3D printed materials, but it will go very fast because, of course, it's not as expensive. The machine is less expensive than a milling machine. We know that the printing machine it's not a big expense, but we don't have any background. And from the literature, we know that it can only be considered as long-term provisionals because the mechanical properties are low. There are some cytotoxicity of some products, and it ages quite fast in terms of stains, etc. So for me, it's not a material for final restoration, but I wanted to say it tonight. But I'm convinced it will evolve, and in the following years, we will have new materials and probably definitive materials. But for the moment, for me, it's not ready.
Amélie, what is your opinion about the 3D printed composites or the hybrid ceramics? when it comes to the subgingival part. I mean, you elucidate how important it is to get a nice seal with the zirconia.
Yeah.
Do we see the same with the composite, or
okay,
do we
so
have a
you
compromise
can look
there?
for the hybrid ceramic. We don't have data about lavage mate and dispersed filler, but about hybrid ceramic, you have this study from my team. You have 2 papers in dental materials. We have studied the cell adhesion to different CAD-CAM materials, and hybrid ceramic was similar to lithium-based glass ceramics. We don't have any monomer release, so it's very good. But for the 3D printed, it's different. 3D printed materials have shown some products have shown some cytotoxicity, and we have some issue with the long-term biocompatibility for the moment. So those materials need to be improved.
You think they're like rest monomers or what inside?
Yes, monomers. Yes, and the cytotoxicity of the products employed. Yeah.
Okay. So would it be an idea to do like a zirconia abutment until the height of the gingiva, and then start with a hybrid ceramic or a printed composite? Would it be an idea? I think
hybrid ceramic is, for me, and we will see it later, a good material for final restoration, but 3D printed is not.
I got it.
Very important to do the difference, because a 3D printed material in terms of wear will wear out very fast. It will stain. Enamic does not stain with time. So because the polymerization process is not the same, it's not the same manufacturing process. So really 3D printed for me is long-term provisional.
Okay.
Hybrid can be final. Okay?
Yeah, perfect.
So it's time to work.
Oh, get me in the ring again.
To Mr. Nightmare, Stefan.
Oh my God.
Because with Mrs. Dream, everything is always good, everything goes fine. But with Mr. Nightmare, it's not the same. So
I know these patients.
You know, Mr. Nightmare. I met. Unfortunately for me, it was already 21 years ago.
I think he moved to Germany.
Yes.
Yeah.
I'm so happy. So you see, Smouse, it was in, I'm getting old, I told you. It was in 24. Yes, it was really more than 20 years ago. You see his mouse, the first time I saw him. In fact, he came to me because he broke his 46. It was a root fracture, and this is something. When you see this in one patient, it should be like a red light. Alert, mayday. But on that time, I was a young postgrad. And I told him, oh, Mr. Nightmare, no problem. We will put an implant and we will put a new material, Zirconia. You will see it will be much better than your old crowns and restoration. And you see, the framework on the implant is totally bad because it's just a coping. It does not support the veneering ceramics, so it's not good at all.
Don't be unfair with you. 20 years ago.
Yeah. And you see that most of all, it has an open bite, so occlusion is not equilibrated. And you also have some attrition facets, which are characteristic of
bruxism.
Bruxism. So he has some bruxism, and all the occlusion is on the molars. Okay, so everything is risky here. 6 months later, chipping, because it's always nice to show beautiful cases, but it's also, I think, more important to look at failures, because we learn more from failures than success. And this patient gave me the idea of my thesis subject. So I tell you, okay, I will do a thesis on chipping on the veneering ceramic of Zirconia in Paris. And so he had chipping. I said, okay, there is a problem with the manufacturing process. Let's redo the crowns. But no, again, chipping during several years. Every time I saw him in the waiting room, I was so afraid. What have you broken again? And finally, in 2014, he lost the 27 root fracture. Implant. I told him, okay, no problem, it's not a nightmare. I have no monolithic restoration. With Zirconia, you won't have chipping anymore. Everything is all right. I have the solution, and you will enter a study, come with us, it will go very fine. 1 year later, root fracture of the 26 and of the 37. So it was a complete failure. I lost 5 teeth within 12 years. And now I'm in 2016, and I have to replace and to put implants for the 26 and the 47. So we put the implant, and here, what would you ask your dental technician, Stefan?
Oh my God, what a horrible case. Amélie, what I learned from you, I think you can only lose in this case. I would definitely avoid, I mean, my feeling in this, I also have these kind of patients, and I would always avoid ceramics on ceramics opponing.
And what would you do then?
Huh?
And what would you do?
I would probably do ceramics opposing composite.
Which composite?
And that is a very good question. Probably a hybrid ceramics with composite.
And which, so do you use already Vitadynamic?
Yeah.
Okay.
Like probably I would do that on a, I don't know. I mean, maybe on a Zirconia.
On a tie base.
On a tie base. Or I would use it, in this case, I would use it maybe cemented in order maybe that I can remove it and redo it again. But help me out.
Screw-retained, why cemented? Screw-retained is more practical. So it's a tissue level implant here, okay? You use
but I could, if maybe it wears, if it maybe breaks the composite, I could just change the upper crown.
You use the screw-retained?
No, then I would go for a cemented, because then I would just maybe go for a new crown on the abutment. But
for me, it's too complicated.
Yeah, it's complicated. You have more joints. You're right.
More joints, and you have to remove it. Screw-retained, it's very easy. You remove, you replace.
Amélie, tell me what you did. There's no one in the chat helping me out. I don't know why. I'm such a nice guy, and no one helps me out. So what did you do?
Stefan needs help, please.
Yeah.
So what is striking when you look at the literature is that most of the studies do not include or even study the influence of high occlusal stress, bruxism. They do not include those high-risk patients. Most of all, we don't have long-term evaluation. And what is also striking, from my point of view, is that most of the studies, they look at the restoration more than the implant success. Because for me, at the end, my objective as a prosthodontist is the implant success. The bone level, I would like to avoid any bone loss, any peri-implantitis. This is my objective. I cannot dissociate this. In some studies, they completely ignore the implant success. And they also ignore the antagonistic teeth behavior, which is also important, because if you lose the teeth in front, it's also a failure. And we know from the literature that bruxism is a potential risk factor for implant loss and prosthesis failure, that we have more peri-implantitis in patients who have wear facets characteristic of bruxism, that overload is something which will alter the bone around implants, and implants do not like overload. We know it.
Amélie, there's an idea from a listener, from Sultan. Sultan, thank you for helping me out. He says, what about a peak abutment? Maybe it has a little bit more flexibility, what we see from peak or PEC?
Yes. So we will discuss about the stiffness. Thank you. It's a very good remark. But the problem with peak is the optical properties. Have you ever look at the optical properties and the wear behavior, etc.? So I don't use it.
And there's another point. Now they wake up. Laura, great idea. She said, "What about a classical metal ceramic restoration with the occlusal area full in metal?"
You are true, Laura. That metal is a plastic material. There is nothing better than a gold onlay for a patient with bruxism. But who would like to have metal like this in the mouth nowadays?
Good point.
We have also some corrosion with metal. We can see some corrosion between the implant and the restoration. So, and at the end, it can also break a bit of the buccal veneer. So it's not a solution for me.
Good.
But I'm happy to see that people awake.
Yeah. Very good. We wake them up.
So let's look at the monolithic zirconia background, because in the States and everywhere, manufacturers sell zirconia for bruxers. There is a company which sells the zirconia for bruxer. In my opinion, zirconia is the worst material for bruxers. The studies about monolithic zirconia are only at short term, and many studies exclude bruxers. So, of course, if you exclude the high-risk patient, you would never have any problem, okay?
Sure.
And it happens that in our team, we have done a study on monolithic restoration. We were studying something else. In fact, we were studying a surface degradation. And we included a lot of patients with clinical signs of bruxism, 61%. And at the 2 years follow-up, look at the success rate. It's only 80% in bruxer. It's very low in prosthodontics. After 2 years, it's very low. Most of the complication in bruxers, of course, and we had implant loss, root fracture, and we are also some disease on the antagonistic teeth. We lost them for root fracture. We had restoration fracture on the antagonistic teeth. And this is really important, once again, to look also at those antagonistic teeth. What is the problem of zirconia with bruxer? It is that if you make the restoration strong and stiff, also very stiff, because zirconia is very, very stiff, you will move the breaker, because there is always a weak link in the whole system, to another point. And the weak link will be, if it's not the restoration anymore, it will be either the tooth or the implant or the antagonistic teeth, because zirconia is very stiff. And there are studies showing that on implants, we need materials with a decreased stiffness. Look, zirconia is very, very stiff. Imagine that enamel is 80 gigapascal, we are 250. And since it's very stiff, imagine you have something very stiff like this, it will transfer all the stresses to the implant, or maybe to the antagonistic teeth. If you have high stress, you need to have a material with a damping effect of this occlusal stress. It's the principle of the night guard, in fact. And towards this property, zirconia is not good at all. We should move to composite material, which contain resin, which is able to deform and to absorb the stresses. And so here, this is Mr. Nightmare, sorry. Mr. Nightmare. What did I do? I put hybrid ceramic, and you were completely true from my point of view, to look at the couple of the different materials.
I was lucky.
And to associate the zirconia with in front a material with a damping effect. And I have to say, I didn't have time to describe this more tonight, but look at this PICN crown 26. It was done with our 1T1T protocol. I don't know if you have already heard about it, that we have developed with France Lambert, and which consists of putting the implant and the final crown the day of the implantation. Mm-hmm. I told France, if it works with Mr. Nightmare, it will work with everybody. Yeah. And it worked. It worked. Look at the other side. He had some PFM crown, and veneered zirconia here, and veneered lithium glass ceramic. Look at the wear. Look at the fracture. It was like this at the beginning. Mm-hmm. Look, as it was a strong wear out. It becomes very abrasive with time, very, very abrasive, and you encounter fractures, etc. But if we look at the teeth on the other sector and the implant, from 17 to 24, Mr. Nightmare became Mr. Dream. And I did not encounter any other failures. So if we look at the situation at present, you can see that the hybrid ceramic becomes matte. We are now at the 9-year follow-up. I encountered one debonding, and I just rebonded again. I have to say that we encountered many debondings from the CEREC tie base. It was a CEREC tie base because the CEREC tie base is not adapted. It's very conical, and and the fit of the dynamic block on the abutment is not good. So I had to rebond it again. But look, full zirconia does not wear, but it's not good. I do prefer to have a material. It's not ideal, I know, to have a matte material. I would like it to be more glossy. But most important to me is the success of the implant and of the teeth. So with this, my conclusion is that implant prosthesis bone antagonistic teeth constitute a complex biomechanical system, and we cannot dissociate all those elements. There is no universal biomaterial, and the choice must be guided by the clinical situation, the type of patient, the other restoration in the mouth of the patient. So there is not only one answer, but we have to rely on our clinical judgment, and we should be able to communicate to the dental technician what we would like. Which type of lithium glass ceramic? Which type, oh, sorry, it's in my house, sorry. Which type of zirconia material? And if hybrid ceramic, which type? So this is a bug. I haven't done anything there, so I hope my husband will look at it very fast if you want to look at the audience. I'm sorry, Stefan, I think you should stop my sound for a moment.
Yeah, no, it's fine. We don't hear anything, that's fine.
No, you don't hear it?
No, it's fine.
There's an alarm in my house.
No, it's fine. Just continue. It's everything fine.
And that's all.
Oh, so you ended with an alarm. Amélie, that was amazing. I loved your presentation. I learned so much about it, and I think I have to go back to the books because it is really amazing work what you did, not only from a scientific part, but also from a clinical part. So the people on the chat, they applaud you. There are some more questions. I mean, I think we woke the people up. That was amazing. There was obviously one question which also came to my mind. What about night guards in this bruxism patient? Should we do it? What do you think?
Yes, all my patients with bruxism get a night guard. It's not always easy to sell them, but I take a lot of time to explain to them the reason and to adapt it, and most of my patients wear it. But for example, Mr. Nightmare does not want to have a night guard. Oh. And we have also to realize that when we have multi-unit restoration, we can, I didn't have time to talk about it today, but of course I cannot go for hybrid ceramic because it's only appropriate for single unit restoration. And when we go for multi-unit restoration, I always tell the patient, okay, you have a zirconia bridge, but you need the night guard on it. It's mandatory. What I can also do on multi-unit restoration, sometimes I do a zirconia framework and I bond hybrid ceramic on it, hybrid ceramic crown on it. This is also an option.
There's one more question about the debonding problem of enamic and tie bases. Do we see that more often? And I mean, you also already alluded to it, then you just rebond it, right, if that happens?
So debonding from the tie base in the 1T1T study, we did the restoration with the CEREC system, share side, because we put the implant and the same day we put the final crown. And the problem is the CEREC tie base. It means it's manufactured with a block, with a hole, which is manufactured in advance by Vita, and then you put it on, you glue it on the tie base, okay? The problem is there was a misfit between the block and the tie base. And so we encountered many debonding. This tie base is very short. Thank you to my husband and my kids. The alarm has stopped. We have imagined, I have to tell the audience, we have checked everything for this session except the alarm system of my house.
Okay, I'm happy nothing happened.
Sorry about it. With the CEREC system, we encountered those debonding because of the design of the CEREC tie base of Dentsply and because of the fit of the block to this system. But since we have moved to, we have worked with Straumann implant in that studies, since we have moved to the Vario base from the lab, so now we send the restoration to the lab, and they come back from the lab on a Vario base, classical Vario base. So we have a better fit. We have a proper tie base with correct height, etc. We haven't encountered any failures anymore. So it's very important to look at the design of the tie base, the fit of the crown on the tie base. Yeah.
Amélie, thank you. There's one more question from Michael. Probably not your topic so much, but I guess there's not much literature around it. Do we see more bone loss when we use these hybrid ceramics? Probably no research on it, right?
There is no research on it, and my idea is to develop research about this concept that I have tried to explain. How can the material influence the bone loss around implant? Because it's very important. There are many parameters we know to bone loss. You know it better than nobody, but prosthesis material, in my opinion, this is my hypothesis, is a very important parameter.
Yeah, more parameters, height of the implant, polishability of this transmucosal seal, and so on. That was amazing. There are two more questions. Maybe you can just answer them very quickly. We are already up in the time. What about orthodontic analysis in a vertical growth type? I think this is a big question. Do you do that when you place implant, probably in quite young patients? Just maybe one sentence. Is there something?
Improposition is something very frequent. We know that it happens in following the literature around 50% of the patient. It depends on the age of the patient and the profile, long phase, etc. In our clinical practice today, we try not to put an implant before 25 or 30. And I do develop a lot resin bonded bridges. It works very well. I love to lecture about it. So this is my first choice in many cases to avoid this problem, yes.
And by the way, there's an amazing Just Ask with Nicole Winitsky about that topic. She did her PhD about that. So please have a look at the previous one. There's a whole Just Ask about infra positioning. One very last question. There was no anterior guidance in this bruxism patient, of course. All of them, they lose their guidance, canine and anterior.
It depends. In that case, yes. And most of all, he put his
tongue. A lot of them, right? Lose it.
The open bite is related also to the tongue position.
Yeah. Would you consider to sort of rebuild that again? Would that be an idea?
In Mr. Nightmare?
Yeah, that's a question we have.
No. He does not have any dysfunction on the joint. He does not have any symptoms, anything. So I don't change his physiological function, no.
I think the idea was to get less stress in a group function thing.
Yes, of course, it would be more convenient.
Yeah.
Anyway, we'll put his tongue to push his tongue between his teeth. And I think my philosophy is to adapt the material to the clinical situation, not the clinical situation to the material.
And if there are no symptoms, why would we do it, right? So Amélie, that was amazing. I loved it. And I'm a periodontist and I could speak with you another 2 hours about prosto. I learned so much and everyone loves you. They applaud you. No one heard the alarm. I actually didn't hear it. So everything was perfect.
I don't understand how, because here it was
it was amazing. Everyone who wants to see Amélie again, you can see her in Lisbon next year.
Yes, I will be
annual congress. Come there. It's an amazing city. It will be an amazing presentation. With this, if anyone has more interest in education, look at the EAO homepage. We have a lot of opportunities, a lot of offers. So have a look at it. With this, come back in 4 weeks to our next Just Ask. We will also have a great topic there. And with this, Amélie, I will leave you to your evening. I hope with no alarm, maybe with a glass of red wine. Say hello to your family. Thank you very much on behalf of the EAO and the board. It was amazing. The people loved you. With this, good night. Ciao, ciao, all around the world. See you next time. Ciao.
Thank you, Stefan. Thank you. Thank you. And see you in Lisbon.
Yes. Bye.